So good afternoon, everyone. My name is Lisa Osqui. I'm a senior program manager with PCMCH, Provincial Council for Maternal and Child Health. Thank you so much for joining us today at our webinar series for the Pediatric Diabetes Network and the Ontario Pediatric Bariatric Network. Before we begin, I just a couple of things to note. Towards the end of the presentation or the webinar, we will have some time to take questions. So please feel free to use the Q&A box located at the bottom of your screen to type in your questions at any time, and we will try to answer as many as possible at the end of the talk. Now, with that said, it is my privilege to introduce you to Dr. Brenden Hursh, who is going to talk to us about an evaluation of a province-wide type 1 diabetes care plan for children in the school setting. Dr. Hursh is a pediatric endocrinologist at BC Children's Hospital in Vancouver, and he works in a multidisciplinary pediatric diabetes clinic. He provides care for families across BC by telehealth and has specific interests in the development and assessment of diabetes care for children in the school setting. Dr. Hursh is a consultant for BC Provincial Diabetes at School program, and he and his team currently provide daily diabetes care at school to nearly 400 children from across BC each year. In other related work, he has been a medical director of BC's Provincial Diabetes Summer Camp for the past 9 years, and his academic interests include the evaluation of telehealth care for children with diabetes. So I'd like to give a very warm welcome to Dr. Hursh and pass it over to him to begin with a land acknowledgement from BC and following his talk.
Hi, everyone. Well, good afternoon. It's so nice to be here. Such a pleasure. It is, I find it interesting that I am providing your lunchtime entertainment. Of course, it's just the morning here and we're just getting started with our day. So you all have been much more productive already today than I have been by virtue of your time advantage. So I love that you're settling into lunch, hopefully, and I will hope to provide you some interesting information and entertainment over the next hour. This will be a success to me if we have some engagement and interaction too. I am here as much to learn from you as to share information about what we're doing in BC. So I hope to hear from you as we go along with this conversation today. Lisa will be monitoring and she can let me know. So put your hand up if you have something to say or enter it in the chat box and we will try and go through those questions at the end. I'll start today by acknowledging that I'm joining you today from the traditional, ancestral, and unceded territory of the Coast Salish peoples, and that includes the territories of Musqueam, Squamish, and Tsleil-Waututh nations. And I'll take this opportunity to commit myself to the struggle against the systems of oppression that have dispossessed Indigenous peoples of their lands and denied their rights to self-determination. And this work truly can unite us across Canada and beyond. I have some goals for us today. The first one is to provide you a little bit of a history lesson around the development of diabetes care in the school setting in BC. I found that that's really interesting because all of us here today will have entered into diabetes healthcare at some point along the timeline, but often we're not aware of the things that have come before us. So I have learned a lot by thinking about it through this wider lens. I'm going to go over how we provide care in school. It's quite a task. Around 400 or 500 students in BC are receiving diabetes care in school on any given day, and that's a pretty amazing fact. And then the work that I've been involved in both 2017 and again in 2020, we've done evaluations of our care in school, and we've solicited feedback from different stakeholders, and I'd like to share some of that data with you. And hopefully in this conversation, we can get to some of the learnings that might come out of our experience in BC toward Ontario, and maybe you'll share some things back with me. That would be excellent. And finally, I like to think of the work with diabetes in school to actually help me think about what this tells us about diabetes care more generally in our approach to youth and families living with type 1 diabetes. I found this slide interesting. This is from a new paper just published from Anne et al. From St. Louis. And the point is that there's lots of arrows and lots of lines. Some of the acronyms are American, so they don't necessarily make sense to us in terms of our programs. But if you look right in the center of that oval, we have the student with diabetes. And then we have the web of connections from that student to their teachers, to school nurses, to classmates, and all of the interrelations there. And we've got the school environment, the physical environment that they're in, the food and dietary environment that they're provided, school policies and organizational capacity like staff training and communication and leadership. Okay, and that's all within the bubble of the school, but of course, right outside that, we've got the parents on the upper right, parents of students with diabetes, and then we've got the local hospitals and healthcare providers, some of whom are in the room today, connecting into the web of school connections, connecting with teachers, connecting with school nurses, connecting with classmates and peers. And of course, above all of that, we have policy and social environment, our provincial, local, and school district policies, and the community resources. And this is one of the things that's so variable across our country in terms of the resources and guidance that's available. So I'll tell you a little bit about how we do this in BC, and the BC model is a delegated care model. What delegated care means is that authority is given under some individual's license for someone else to do a task. This is fundamental to the way we do diabetes care in BC. So this means that someone, and in our case, it's a nurse coordinator, does the training and ongoing monitoring and supervision of an EA, educational assistant, who is a staff person who is not medical. So this is a pretty big task for them. And that the nurse's role includes oversight of the child's response to the care that's being provided, and understanding if it's appropriate to be delegated or if care needs to be paused or withdrawn because it's not meeting the standards of safe delegation. Okay. And the parents are always the first call if a child's requiring care that is outside of what is delegated or planned. In other words, outside of routine, repeatable diabetes tasks. So in order to do a delegation, the child in the school, the care must be relatively stable and predictable with expected and consistent responses to interventions. Okay, and that's relative to diabetes too, of course, which always has its ups and downs along the way. And the tasks are tasks that absolutely need to happen in the school time. So we don't deal with things that could happen at home, like calibrating a continuous monitor. That could happen at home with the family unit. And the tasks need to be routinely scheduled. So delegated care doesn't deal with things like, well, maybe one time in the future, the child would like to have one injection of a special insulin, right? It has to be, what is the routine every day so that the people giving that medication can be well trained in it and have practice with it. The tasks need to be relatively simple. They have to follow an algorithm so that a non-medical person can follow the guidelines and understand what to do for any event that happens throughout the day. Okay, and of course, in this setting, there's lots of environmental and staff factors around the complexity of having staff in the school setting and having those people be trained and hoping that they stay there for some time to work with the child continuously. So you'll hear me talk in our talk today about nursing support service coordinators, and nursing support service is the umbrella program that provides this care to youth in schools, and they are the ones who are assessing if delegation is appropriate and then providing delegation to the school staff who will carry out diabetes care. The nurse works with in collaboration with the family to create the care plans, and then they delegate the specific type 1 diabetes task to the educational assistant in the school. They monitor it to make sure it's going well. They monitor the child's response to make sure that the care is appropriate. And these are not necessarily diabetes specialists, although many of them gain lots of experience with diabetes along the way. And they receive some education every year around type 1 basics and type 1 delegation, and yearly, now we do yearly technology updates too for them. This program has been in existence for over 25 years, supporting children in schools. And the nurse's role, just to be clear, is not to provide the diabetes management. So the nurse is not the one, I don't know, changing a pump site or pushing the buttons on the pump. That role is delegated to the school staff if it's appropriate to do so. Our program in BC is voluntary and optional. Okay, that's an interesting concept because sometimes people are frustrated that the program is not exactly what they would like. So it's important to know that people are not mandated to receive care in this way. And some families may choose to do care differently or guide it themselves. But it is an optional program. We work in collaboration with the diabetes clinic team. And we have primary goals of keeping youth safe at school and in a good learning environment, and also supporting the child toward development through their time with the program. And we often come back to this, but clearly diabetes care in the school setting will look different than care at home. And that's been an important idea to ruminate on a little bit with all of the changes that are happening around diabetes care recently. Parents collaborate with the coordinator, and we have been working over time to understand what individualization means for families and how to allow as much individualization as possible while still providing a good, safe care that follows guidelines. So some of those parameters that are flexible within our care plans would be what fast-acting carbs are they using for low treatment and how much within the guidelines. What parameters for blood glucose or sensor glucose are we using for different types of action or insulin administration? Outside of the high-risk times like physical activity and lunch, we allow families to choose what scheduled glucose checks they would like, and thinking about what the snack options are for the children. Individualization is a theme that also has run through most of our evaluation of the program, with trying to find some balance between allowing individualization while still making sure that we're providing equitable and safe care across a wide variety of settings and a wide variety of families. So these are some of the things that youth need to do to be able to have care in the school setting. They have to be able to carry low treatment on them. Remember, these are kindergarten or older kids, and so this is just generally a reasonable thing. If they are using continuous monitoring, they need to be able to carry the receiver with them. They need to be cooperative around glucose checks. And if they're feeling low or high, or they have an alert, they need to be able to let someone know. We have a plan that works for most people, and we also have a process of medical exceptions. We try to do this in a really formal way so that each one's evaluated thoughtfully. But of course, questions do come up that are reasonable, that would be outside of the boundaries of our normal care, but that are made essential based upon someone's unique circumstance. So I've given an example at the bottom of perhaps a child with autism who requires an alternative fast-acting carb that may not be in the usual plan of low treatments that we use, but perhaps in this setting, it has been documented that it works for this child. It is the only palatable option that they possibly could use, and their medical team is on board and supportive of it. That would be a very reasonable request for us to consider. And we try and find a balance there between what is a true medical exception and which ones are simply preference and can be accommodated within the boundaries of our overall care plan. So now let's do a little history. Going way back, as I said, a couple decades, we've provided oversight of diabetes care in the schools. But for anyone who enters into the diabetes world now, it's quite mind-blowing to think that it was only in 2008 that insulin pumps were approved for kids in BC. And actually, prior to then, and even at that time, there was no plan for kids to receive insulin in schools whatsoever. So in 2008, if a child showed up with an insulin pump, the school would supervise the child pushing the buttons on it if that was safe, but they would not operate the pumps at all, and they weren't doing any insulin injections. And so that rapid acceleration in the level of potential for good diabetes care really was hitting a brick wall with the level of care that was able to be provided in schools. And in 2010, there were human rights tribunals with the request for better care for children in schools. Parents at that point were starting to make their own care plans. So in other words, going outside of what was the official diabetes in school program, which comes with some benefits for the families, but also some risks potentially as we lose a kind of standardization and best practice. And so over the next 3 or 4 years, there was a big working group. There was support from Child Health BC, which looks over provincial care in the province, and the tri-ministries in BC. And the end result was that in 2014, we had the mandate that we were able to do insulin administration in schools and insulin pump use in schools. So that was 2014. And about 3 years later, we did our first full evaluation looking at school staff and families and their perceptions of safety and management in the school setting. And I'll share that with you. And also around that time, those of you involved daily in diabetes management will know that that's also around the time frame when we started to have not only continuous monitors existing. So for non-diabetes folks in the crowd today, this means the difference between going from a finger poke 3 or 4 times a day, or 5 or 6 times a day, to having a sensor which is giving you information literally every 5 minutes throughout a day. Okay, so suddenly we're moving exponentially higher in terms of the amount of data that we have on children. And then some of that technology was labeled as non-adjunctive, meaning we didn't even need finger pokes anymore. We could just use sensors. So it was in 2018, only 4 years ago, that we launched our first pilot program to say, what would it look like if kids in school were using sensors? And with a number of families who were starting to try that out with us. And we march forward now to a world where sensors are absolutely the majority 3 or 4 years later. And as a diabetologist, it's interesting to me that now, here we are, over a decade from the last set of human rights tribunal, we find ourselves in somewhat of a similar situation. We have a rapid expansion in the ability for diabetes care, and therefore we have a rapid expansion in the desire of youth and families for that excellent level of care to be available in every corner of their life. And so it raises some really good questions about how are we adapting to the future of diabetes care, and how are we doing that in a way that's sustainable? I'm going to show you some interesting data on that. So what do we know about diabetes in the school setting? You may have numbers for Ontario. In BC, if we have over 2,000 kids with type 1 and around 1,000 schools, the likelihood is that there may only be 0, 1, 2, or a few kids in any given school with type 1 diabetes, which sort of means we're reinventing the wheel each time in terms of staffing and education. And many youth may not know another child in their school who has type 1 diabetes. And we add to that what we know, which is that on the right here, classes with 4 or more students with special needs are increasing, class numbers are high, and what a complex setting for teachers and educational assistants to be working in. And then, of course, a child with type 1 gets plopped in there with their specific needs for care. So if we go back 8 years, this is what our care plan looks like. You're not supposed to be able to read the details. You're supposed to be able to see that it is kind of an overwhelming document with lots of text that's black and white and not easy to follow and easy to get lost in. But it did follow the general principles that we used. It marched through the daily flow by time event, arrival, snack, lunch, before physical activity, and then had a plan for what to do based upon the blood sugars at each of those times. And this is in 2017 where we said, okay, well, let's start to get information. And to our knowledge, this was the first study of a provincial diabetes plan in Canada. And it provided us with some really novel information because we didn't really have much of a sense. We were hearing some voices that were loud, that were not pleased with diabetes care in school. And we wanted to get a sense of whether that was the majority or not. So back in 2017, we got information from 160 parents. The kids, you can see down from the bottom left, they obviously build up as you go, partly just simply because of the onset of diabetes. And we end up with kids really through the kindergarten through grade 3 or 4, and then tapering out grades 5, 6, 7. And with very few beyond that point. We also had 45 of our coordinators. I think there were around 60 total at that point. Those coordinators are from across British Columbia. And you can see from the bottom left, the average number of children that each coordinator was supporting was somewhere between 10 and 20. So these coordinators were actually having quite a lot of experience, and over half of the coordinators have worked for more than 5 years, so which is quite remarkable with the Diabetes in School program. So this is back in 2017, and we were quite pleased with this information, and it also made us smile. So the quite pleased part is that if we looked at on a scale of 1 to 7, and if we said that the child's diabetes at school is not managed at all, 1 to 2, it's managed somewhat, 3 to 5 in the middle, or it's managed very well, score of 6 to 7. This is the family's perspectives, and in the lighter color, we see that almost 2/3 of families found that their care at school was managed very well, and about 1/3 found that it was somewhat managed. Now, interestingly, the part that made me smile is that families generally perceive that they do a much better job at home. And with 85% of families feeling that they do a good job at home. And I can say that I would hope for numbers like that in our diabetes clinic population. So there's a little bit of a interesting perception there on the family's part. But overall, I think for a first shot at this, we were quite impressed that almost 2/3 of people thought that things were going very well in terms of diabetes management at school. And this is again on a scale of 1 to 7, and we asked some important questions. So this is that question, how well is it managed? And now here, rather than with the bar graph, I'm showing you the numerical data with mean from 1 to 7. And we're looking at families in the left column and coordinators in the right. And so we've got scores in the between 5 and 6 out of 7 on average for both families and coordinators in terms of how well care is managed. And then the next question here, how well does it support safe care in school? And again, overall, really good average scores, 6 or 5.7 out of 7 in terms of safety at school. But I want to highlight one of the interesting findings here is that there is still this small percentage number that felt that the care plan was not meeting their needs at all. A small number of families and 5% of coordinators felt that the care plans were just not working for them. Same thing happens when we go down and we look at the bottom, overall satisfaction with care plan document. Overall for families, they're quite pleased with the document, with the exception of several percent. And coordinators less happy with the document. They're the ones who are working with it constantly. This is that black and white overwhelming document I showed you. I'm not that surprised that people weren't too smitten with it at that point. This is back in 2017. Now, there was no CGM, continuous glucose monitoring, in the school setting. So we asked, does your child use CGM as part of her diabetes in the home setting? And so this is back in 2017. We're looking at 30% of families using CGM. That number is now more than doubled. So that gives you a slice of where we were at. So a third of families were using it in their home setting with early CGM technology. And then we come down, and almost 4 out of 5 families would have liked to see that integrated into the school setting, and 100% of the coordinators would have liked to see that integrated to the setting. So this gave us a mandate from 2017 that said we need to wake up and get working and start thinking about integrating continuous glucose monitoring into the school setting. So from 2017, our findings were that we had overall high satisfaction from families around care in BC schools, of course, with room to improve. And it is essential to understand more, particularly from the coordinator group, around the group that is not finding it's meeting their needs. And some of the steps that we worked on were clarifying our philosophy so that there was more alignment between the coordinators and families in terms of really clear communication of what the goals of the program were, and working in collaboration with the diabetes team. And it was clear that there was more interest in supporting CGM, more frequent insulin administration, and care plans that were more user-friendly. And so I'll show you this. It's actually, in a talk like this, it's overwhelming to try and walk you through the entire care plan and what it looks like. If anyone has a particular interest in this, I'd be happy to connect with you afterwards and do that with you. But this is an example of what the page might look like from lunchtime. And these were changes that came out of that initial work. And the most thing that catches your eye first, of course, is that this is a bright and colorful document. And so what that looks like is we started to color code it so that it was clear. This is looking at what your sensor glucose level is on the left. It was clear immediately based on your level, whether you were in a red zone requiring action right away, whether you were in a yellow zone where there is possible action, a green zone where everything is in the clear, or then on the higher glucose levels, a yellow zone and a red zone. Okay. And the other interesting thing here, and probably the niftiest thing that we've been working on, was trying to figure out back in 2017, 2018, what on earth to do with the fact that continuous glucose monitors not only tell you a number, 4.2 or 5.8 or 10.1, but they also give you a prediction of where the glucose is heading. So we started to play with ideas around what would you do if the glucose is in this range, 4 to something, whatever the family chooses, with the coordinator, but the arrow is double down. Perhaps we do one thing. Maybe the arrow is sideways. Perhaps we do something else. And maybe the arrow is heading upwards and we do something else. So I told you our fundamental idea, keep things really simple for delegated care. CGM is pushing the boundaries of that because all of a sudden we now have way more potential outcomes on this algorithm of choices because of the complexity of having so much more information. So this is a question. This forum on Zoom isn't wonderful for shout out loud and let me know what you're thinking. So I'm just going to put it out there for you to ponder in your own mind. But in your own opinion, and now you may be a school staff person, you may be a physician or a nurse clinician, you may be a policy person here today. There's lots of different people with different roles. I think we have dietitians and social workers, hopefully in the crowd as well. So in your own opinion, for people living with diabetes, advanced diabetes technology, pumps, sensors, pumps that talk to sensors, all of that, do you think that it's great? Absolutely, no doubt. Do you think it's good, but it comes with trade-offs? Do you think it comes with some serious drawbacks? Or do you think it's really problematic and perhaps it would be better if we didn't have to think of it at all? So I'd like you to think where you stand on that one. And now think about what you think about that same question, but in terms of its impact on healthcare providers. Is it great for healthcare providers? Is it coming with some trade-offs? Is it coming with some serious drawbacks? Or is it really, really problematic for you in your role? And maybe it would be better to stay like things were in their past. The reason why I ask that is that I know, because I was in the conversations, before we started working with CGM in schools, there was tremendous hesitation around it. The narratives from our healthcare providers in all sorts of different settings, the school setting, but also the clinic setting, was that this was something that would come with large drawbacks. And I'd love to hear from anyone if that's a similar shared experience. There was lots of worry about CGM in schools. This was going to be kind of the downfall of the school environment. The kids were going to be way more anxious. The beeping would be nonstop. There would be no way to be on top of it. The plans would be too complex. There was lots of warnings by healthcare people around what this technology was going to do. And I think also lots of barriers or guarding against the quick and early adoption of sensor technology. So now we bump forward. This is data just from a few weeks ago. We've got about 400 kids on delegated care in BC. And what's our number now? 70%. I told you in 2018, we started a pilot program with 10 or 20 kids out of 500 or 400 or 500. And now we're looking at 70%. So several hundred of these children are using CGM in school every single day. And that's quite remarkable. Here we are now looking at, I've shown you the data from our 2017 study, and now we jump forward in time. So this is 2020. And in 2020, we did a couple of interesting things. We accessed our families again. We got 120 of them to respond. We accessed our coordinators, and we got 36 of them to respond. But we also did several more groups. We asked the school staff. We had an absolutely robust response from them. 290 staff members wrote into us and gave us their opinions on their survey. And we also tapped into a new group here, the children. So this is not the family doing a survey for the children. This is actually a specifically designed survey asking kids their thoughts about what's happening in school to be filled out by the children themselves. Okay. And again, most of these families have kids in the grade 2 to 4 range is most common for our program, but starting right at kindergarten and ending at about grade 8. And I'll orient you to this slide next. I've put up here our data that I already showed you from 2017 for these two questions. The first one being how well is diabetes management and how safe is it? And then we can do two things here. We can compare, so BG means blood glucose. So a finger poke care plan from 2017, and we can compare it to the kids using finger poke in 2020. And when we look at that, we actually see a preservation of the scores over time. Now, this is not apples to apples, right? Because I think a lot has changed from 2017 to 2020. A lot has changed in terms of technology. A lot has changed in terms of families' expectations for diabetes care. We continue to be more and more aggressive in terms of diabetes management, I find. So the world has shifted. But here we see that families using our finger poke care plans, overall, we're seeing similar or improved sense of diabetes management at school and similar or improved sense of safety in school. So I was really pleased to see that. And then what we can do with this graph is look at the second two columns, which is comparing blood glucose finger poke care plan in 2020 to those kids using CGM. And again, this isn't exactly apples to apples either, right? Because kids on CGM are going to be different by their nature. We're going to be selecting a different group of parents who are responding to this. And the sense of management is higher on the kids using finger poke care plans than CGM. Still good though, 5.5 out of 7. I think that's pretty remarkable, with 7 being excellent care and 4 being kind of a neutral response, 1 being terrible. And then we also look at safety, and we see that safety is also a little bit low. Sense of safety is a little bit lower on the CGM care plan. But one of the reasons we did this was to make sure we weren't having a major signal around unsafe care using CGM at school, and that's clearly not the case. 5.9 out of 7 on average. But there's 2 signals here that are interesting. One, the families tend to think that the families on a CGM care plan up here seem to think that the management is not as good as the families who are using BG ones. And the coordinators who are using the CGM care plan seem to think that there's some concern regarding the safety of these kids on CGM care plans compared to how fondly they think of the finger poke care plans. We asked some other questions too. How well does the care plan describe diabetes needs? Overall, I think very good scores and reflective of some of the improvements that were made over that interval 3 years. The satisfaction with the physical document that they use, that I showed you, that color-coded complex document. I think we've seen big jump here. So some of the things that we did to make wayfinding easier have helped. We were at 5.7 and 4.6 out of 7. And now here in 2020, the scores are higher. And how easy is it to find information? And also now we've moved from the 4s and 5s into the 5s and 6s for those scores. So some simple changes have made a difference in the use of the care at school. This is perhaps a different way to look at it, but again, this is now looking at that question of management of diabetes in school. 2017 is on the left here. And we see the coordinators and then the families grouped between somewhat well managed and very well managed. And as we move into 2020, we see a preservation of that curve and adding in the school staff who are actually really impressed with how well things are happening in the school setting. I thought that was a really nice signal to see. And then when we compare 2020, the finger poke in the middle to the CGM care plan, we see the school staff continue to be really impressed with how things are going in the school. And the one group that seems to not be so impressed is the families are much more limited in their enthusiasm, with more of them feeling that we're only somewhat meeting their goals for management. And this is perceptions of safety. And again, we see a nice preservation of that curve here regarding safety. And I mentioned the coordinators in blue over here on the right, the only group that's being more reserved in their enthusiasm for the care plan. We did ask them, what do you think specifically, how has the addition of CGM changed care in the school setting? And overall, very positive, 4.9 to 5.9 out of 7, with a score of 7 being a very positive impact and 4 being neutral. So generally, all of the stakeholder groups felt that the addition of CGM is positive. And what I'm about to show you, I think, is one of the most striking things here. So this is positive changes with CGM in the school setting. This is the impression of coordinators on the left of each triad, school staff in the middle, and families. And look at how much positive feedback we're getting for CGM in the school. These kids are getting less finger pokes, less anxieties for the family. The kids are getting to activities faster. The kids are more independent. There's reduced anxiety for the school staff. There's reduced anxiety for the child. Classroom is less disrupted. Things are safer, and we're doing better with blood sugar management. wow, even a number of the families felt that the kids are doing better in school as a result of being on CGM. Isn't that remarkable? So I show that thinking back to that earlier conversation about how much hesitation people had around introducing technology into the school setting. Now let's look at the negative changes. There's a lot we can take out of this. School staff and families report almost no negative impact of CGM. And indeed here on the right, on the very right side, we have 70% saying there were absolutely no negatives to using CGM in school. That's families and school staff. Our coordinators, however, so these are the people who are feeling the responsibility of the plan, who are having to teach the families how to use the plan and having to teach the EAs how to use the plan and setting up the plan and dealing with the feedback from the families on the plan. And what do they think? So the nursing coordinators, the ones who aren't actually in the school, harbor, half of them worry that it will make the school staff anxious. Now we learned that the school staff don't think it makes them anxious, but the coordinators think it makes them anxious. They worry that there will be increased anxiety for the child, although the families don't think that. They worry that the classroom will be more disruptive, although the school staff don't find that. They worry that there'll be more anxiety for the family, although the families don't think that. None of them thought that. So how interesting that there is something going on within this setting that is leading the medical professionals to be the ones who continue to be most hesitant about this technology, despite really clear feedback from families and school staff that this has been a really positive addition. And we can put those two graphs I just showed you on top of each other to highlight this. And you can see the paucity of negative impact and the tremendous amount of positive reported changes. And you might ask why. And so this slide, I think, gives us a really interesting idea of that. To walk it through, the NSS coordinators on top and then the school staff below where it says EA, impact on workload. NSS coordinators find CGM much more challenging for workload. They find CGM much more challenging communicating with family, and they find the delegation to the EAs much more complex. And they find the time that it takes them much more complex. Meanwhile, the school staff find that it's been a positive impact for them on their workload, on communicating with the family, and on the time they're providing care in the school setting. So what we've done is we've introduced diabetes technology, which has a disproportionate negative effect on the healthcare professionals and the complexity of their jobs, and they're stretched thin. And I think that's why we continue to see the harboring of these hesitations around it. And the last thing I'm going to show you today, and then we'll stop and have some time for questions, is what are the perceptions of children? So these are the responses of children, kindergarten through, as we said, grade 5 or 6 or 7, and what they think about using CGM at school. Do they feel safe at school on the left? More of them feel safe at school when they're using CGM. Are you happy with the diabetes care you get at school? More of kids on CGM feel that they are happy sometimes or all of the time. And this is just to the kids on CGM with CGM on the right side. Do you like having your CGM at school? Nearly 100% of them answer that they are always or sometimes enjoy having their CGM at school. And what do they tell us? Well, their biggest benefit is not getting their fingers poked all the time, but they also find they get to activities faster and they miss less activities and they feel less worried about their health and they miss less class. And a comical one, of course, they wash their hands less often and they feel less distracted in class. All really wonderful feedback around CGM in school from children using it. And do they notice negative changes? Well, the summary here, the first 4 are all about alarms. And I think that's not unexpected. Do the alarms draw attention to them? They don't like everyone knowing that they have alarms. Sometimes I don't hear my alarms and maybe there are too many alarms. And then maybe tied into that is that when my alarms are beeping, I have to wait for my EA alarm. So overall, we have some interesting information here around the positives and negatives, with some pretty dramatic positives of using CGM in school from the kids' perspective. And a final brain teaser for you is, are you able, as a healthcare person or a school person or a policy person, able to stay up to date on diabetes technologies? Do you feel completely, somewhat, or not at all? And when we asked our families that, in blue, our families, the majority of them, over half, say they stay completely up to date. However, the healthcare professionals struggle with that, and they feel that they only somewhat stay up to date. And if we look at how families get their information, the model of families coming to health professionals and everything health professionals say is exactly what the families know is no longer true, right? The diabetes team accounts for only 30% of where families get their information. They're getting an equal proportion from social media, independent research. They're also using vendors and websites. They're reading books and other sources. So I've shared with you a lot today. We have 12 minutes left, so we're going to break for some questions. So I'd like you to think if you have anything you'd like to ask. But I think I would close by saying that Diabetes at School has provided us with some really interesting insight into modern diabetes care more generally. It's absolutely challenged my assumptions and biases that I had going into this work around things that we thought we should be really worried about. And yet there is a flip side, which is we really have to think about the capacity of the healthcare system and how on earth we continue to advance our diabetes care, advocating for youth and families to get the best care possible, but recognizing the signal from the nursing coordinators that this is making their jobs so much more complex. And we really, in step with advocating for youth and their care, we need to advocate for our healthcare system to have the capacity and the skills to be able to provide this care for them. Because I'm continue to be quite worried about that group that is struggling with the fact that adding technology into the school setting has also added tremendously to their workload and burden during quite a difficult time generally for all of us. So I hope I've given you some interesting thoughts from our experience in BC. I hope some of it is translatable to your Ontario environment, and I'd love to hear if we have any questions or comments.
Thank you, Dr. Hursh. That was great in giving us a glimpse of the BC model. We do have a question, and I'm just going to read it out loud. Given the higher prevalence of type 2 in Indigenous youth, does the program have a specific focus for this group?
That's a great question. We don't specifically. I think our rates of, so this program works very much around the tasks related to insulin administration. It would be fully applicable to any youth needing insulin administration, and something such as a glucose monitoring plan could of course be considered if there was a child that would benefit from having that in school. So again, those two things probably fit together. Someone with type 2 who's requiring regular insulin administration and glucose monitoring. Absolutely. I also think our prevalence of type 2 in BC is lower than some of the other provinces. I don't know what your rates are in Ontario, but we definitely don't identify it as well, and don't see similar numbers to some other provinces.
Okay, just received another one. The nurse does not go into the school on a daily basis. They train the staff, and the staff gives insulin. I guess you're trying to clarify whether the nurse does or does not go into the school for daily basis.
That's a great clarification. So no, then in this model, which is called delegated care, the nurse is not in the school setting. And I think that differs from what's happening in Ontario. So in our setting, the nurse is training school staff. So they work with them quite intensely at the start of the school year. it's getting kids into the school setting and having the assigned educational assistants knowledgeable about what to do. Again, we have the care plan document, which covers 9 or 10 pages, which really walks them through at each time of the day, and for a hypoglycemia or hyperglycemia that occurs outside of those times, what steps they should take. And so the school staff person who's not a trained medical person is able to follow that training and, for example, come up with the right amount of low treatment based upon what the sensor is. A good example, if the family can choose what sensor settings they would like different amounts of low treatment to be. So of course we have what we would all consider a true hypoglycemia requires a proper hypoglycemia treatment, but families can also have something in the range of a blood sugar above 4, but with downtrend arrows, they may wish to have some fast-acting carbs given. So the EA isn't making that decision. They're not filtering all of the things that a healthcare professional or a family would filter to make their decision, right? How active is the child, and do they look well or not, and what has their history been over the past couple of days. They're simply looking at a sheet of paper which gives you a blood sugar, a trend arrow, the time of day that it's happening, and what a safe next step would be.
Thank you. The next question is, what is the biggest barrier to more families accessing the program for their child in school?
Honestly, I think the biggest barrier is the program's available for everyone. And what I found interesting in this work is that the program is generally really well received by most. Okay, like everything that we do, a small percentage of people take the majority of time, right? And a small percentage of people are constantly advocating and trying to push things further. And also a small percentage of people may just simply not fit into the model of care that exists currently. So I think the program exists for everyone if they wish to use it. I think what we're seeing, of course, is as families are developing some families, very intensive diabetes care in the home setting. And by that, what I mean is families that are effectively acting as automated insulin delivery systems, right? Constantly checking CGM and doing small doses of food or insulin throughout the day. And all of us have families that have young kids who have A1Cs that are in the non-diabetes range because they are literally doing 1,000 things all day long. There's no possible way that that can happen in the school setting. There's no way to expect that that would ever happen equitably or fairly. And it's really, I think, an unfair assumption that that would be fair to other kids in the school setting or that child in the school setting, right? To constantly have diabetes interventions. So we try to promote a philosophy where families are able to give up a little bit of that control that they have in the pre-kindergarten age when the kids are at home, or in the time when the kids are not in the school setting, in favor of having positive engagement in school, which may mean being slightly more permissive around the blood sugars not running close to low constantly. But some families just absolutely aren't willing to give that up. So other scenarios that happen, some families in private schools will set up private arrangements with those schools. That's completely outside of this program. And some families will, in public school, also set up arrangements where they are the primary care provider and sort of live in the school setting. Okay, the nursing support services program allows that no family needs that. And we think that the kids get very good care in the school setting by virtue of a care plan that's checking glucose multiple times through the day, administering insulin with a pump multiple times through the day. And that, that I think that far exceeds what many kids receive in the home setting, but there is still this subset population that are doing extremely intensive care. that will, I think, always be pushing for more in the school setting. That pushing is good. I mean, it's got us to where we're at. Hopefully it gets more resources, right? Hopefully this is sustainable before it breaks. That's what we hope for, right? But it's clearly straining the system right now. For all of the positive, I tried to have a very positive lens on this, but I also have to acknowledge the signal from the coordinators that this is becoming a lot of work for them.
Thank you. I think you partially talked about this, but so one of the questions asked that you mentioned 400 kids having delegated care, and that there are around 2,200 kids with type 1 diabetes in BC schools. So what accounts for the difference in the numbers? Parent decline, delegated care, age of the students, older students are self-managing, and how are school staff educated about their needs? It's a multi-pronged.
Totally, great question. Yeah, I showed that number because I think it's interesting, right? You always, if you work in diabetes, you meet so many kids with it. You know, we go to diabetes camp with 100 kids running around with pumps on, and it seems like it's something that's ubiquitous. And when you distill it out, you realize that kids in school settings frequently may not have other children around them with type 1, or teens, maybe the only teen in their high school setting with type 1, particularly as we get into more remote communities. Yeah, but yes, I think you answered the question there nicely, which is that we're talking about not that number is all kids with type 1, but of course we're cutting this off and we're saying, okay, well, we're not including the before kindergarten age, so take those kids out of the mix. And then we are actively working on developing skills and graduating kids toward independence. And that is starting to happen clearly in that 8th grade, you know, at least grade 5, 6, 7, 8. So by the time the kids are 11, 12, 13, they're really working on their own independence. So obviously a number of that number of youth with type 1 also includes that group. I don't actually have a great number for how many aren't in the program, although our overall number is decreased from what it was in 2017, and that does make me wonder with CGM and automated insulin delivery. And also one thing that I didn't touch on, of course, is looping. So looping is using software to connect a pump to a sensor so that the pump is taking that data and making changes in real time. That's not Health Canada approved. All of our program is fundamentally based around using Health Canada approved technology, with the idea that it's not appropriate for a nurse to be expected to delegate care that is not approved in Canada as a official medical device. So yes, there's definitely a subset of families that are doing care outside of Health Canada approved technology and outside of what's really possible for us to do in a delegated setting.
Thank you, Dr. Hursh. We still have a number of other questions, but maybe we can connect offline and get your response, and we can circulate that to the group. It is 1 o'clock, and our webinar time has come to an end. On behalf of PCMCH, I'd like to thank you, Dr. Hursh, for your time and for this amazing talk. Lots of engagement from the group. I see a lot of positive remarks in the chat box as well with regard to the information you shared with us today.
Wonderful. Thank you so much. I'm so happy everyone spent lunch with me. I hope you have a great, wonderful afternoon in Ontario. And if any of this strikes you positively, feel free to reach out. I'm happy to share more information with you or connect with you. We're thinking about this a lot here, as I'm sure many of you are in your own settings. So I hope this provided you some new thoughts and some new data to think about to inform your own practice. But most of all, I really appreciate you spending the time to be with us today. So thank you.
Thank you, everyone. Bye-bye.